Next slide, please. Good afternoon. Thank you for attending this month's Ocean Grand Rounds. I am your host, William Pinnock, and today I could not be more excited to welcome Dr. Sanjay Basu of Waymark and HealthRight 360 Integrated Care Center as he presents on financing social need interventions identified by primary care clinicians. Dr. Sanjay Basu is a primary care physician and epidemiologist. He currently practices medicine at San Francisco's HealthRight 360 Integrated Care Center, a primary care, behavioral health, substance abuse, and oral health center for unhoused people, and serves as head of clinical for Waymark, a public benefit organization that provides social services for people receiving Medicaid. Dr. Basu received his education from the Massachusetts Institute of Technology, MIT, Oxford University as a Rhodes Scholar, and Yale, before completing his residency in internal medicine at the University of California in San Francisco. Dr. Basu has published over 300 peer-reviewed journal articles in such places as, to name a few, The Lancet, Journal of the American Medical Association Internal Medicine, and American Journal of Public Health. He's co-authored the 2013 book, The Body Economic: Why Austerity Kills, has been profiled in Forbes magazine, has been named to the top 100 global thinkers list by Foreign Policy magazine, and has received both the NIH Director's New Innovator Award and the Presidential Early Career Award for Scientists and Engineers. He is the previous Director of Research at the Harvard Medical School Center for Primary Care and currently serves as a Fellow at Imperial College London and an Associate Professor at the University of Toronto. This session is being recorded. Attendees are muted upon entry, so please pose your questions through the Q&A or chat box. This presentation will last approximately 45 minutes with 10 to 15 minutes at the end to answer any questions you may have. We will now pass the mic to Dr. Sanjay Basu for financing social need interventions identified by primary care clinicians. Dr. Basu, the floor is yours.
Thanks so much. Always nice to chat with other members of the Ocean Network. I'm going to share my screen and talk a little bit about some dilemmas that I and others may have helped create for primary care practices and the challenges therein. So many of us in the Ocean Network have for several years now conducted research and published in public health and other venues, work suggesting that social needs has a set of dire consequences when unaddressed for our patients as well as health system. This is just one example of work across the Ocean Network in which patients who were food insecure by the U.S. Department of Agriculture scales that we sometimes use in our practices have higher risks of emergency department visits, inpatient admissions, and hospital days. No surprise to the Ocean Network that's been discussing this issue for years. And associated with that, of course, we also have published much work identifying unaddressed social needs as leading to higher healthcare expenditures. This similarly for food insecurity among patients with diabetes mellitus or hypertension or heart disease, defined as cardiovascular disease or heart failure in this case. They have a higher odds of having any expenditure and a higher incidence of expenditure with higher total expenditures. And we can think about many reasons, of course, why someone who is food insecure might have worse health outcomes. In the diabetes case, for instance, we sometimes see higher visits for hypoglycemia towards the end of every month. In those states where SNAP benefits are at the beginning of the month, people are taking the same amount of hypoglycemic agents like insulin at the end of the month, and their sugars dip too low. Classic cases, of course, in which people who are unable to afford healthy foods tend to have worse hypertension and CHF exacerbations. Now, the logical consequence of this work is that even outside the Ocean Network, which has been discussing these dilemmas for years, as you all know, we've been increasingly asked in practices to kind of not only address these issues, but do some pretty intensive screening and referral for them. And so, as is often joked about in this network, when primary care providers complain about something, we are asked to screen for that very something even more. And so indeed we are screening for social needs increasingly across our network, and using the Prepare survey, other health-related social needs assessment, often screening for housing, transport, food insecurity, domestic violence, a variety of common social needs. And work conducted within this network has suggested that there are several findings. First, that the frequency of screening is variable, like most screening that occurs in primary care practices. A few folks are doing it all the time. Many folks are doing it sometimes. Few are doing it never. And many are directly connecting to resources or providing information upon that screening. But the dilemma consistently found in a number of trials has been what happens afterwards. And so the wonderful Rachel Gold, one of the great OCHIN researchers, published this article, for example, recently in New England Journal Catalyst. It indicated some challenges around even performing the screening, but also what occurred subsequent to it. In this case, I'll quote her directly. 5 clinics withdrew from the study for various bandwidth-related reasons. Of the remaining 26 clinics that were doing this screening for social needs, 19 fully or partially completed all 5 implementation steps of doing the screening and referral. 7 fully or partially completed at least the first 3 steps. And unfortunately, no significant difference was seen in social risk referral rates during the intervention or post-intervention period, and such under-resourced clinics may struggle to participate in support activities over longer periods without adequate resources. So this, like many studies, has sought to see how screening can be implemented and sustained in practice with the many other things that we're also asked to screen for. And critically, what happens? Sure, we can do more screening, but once we document the need, how much is actually getting referred out? And critically, once referral happens, are people actually able to address the need? Is the referral being effective? Um, what if further support was given? So it's not just all on us as primary care providers and our staff, but there's some additional staffing. Laura Gottlieb at UCSF has done lots of work through the Siren Center there, as have many of her colleagues in the Siren Network. And unfortunately, lots of null results that basically suggest even adding assistance, helping walk through the patients to their resource rather than just providing a resource referral the way we do, say, a specialty referral, didn't seem to actually result in more of the needs being addressed, which is what we would have hoped for. And increasingly, the suggestion has been brought in by states, including many of our states, that the problem is our inefficiency in primary care. And so the suggestion has been made to automate more and more of the screeners through our electronic health records. So that certainly has been done in many locations. For many social risk factors, the sensitivity is moderate to high for some, but you can see some pretty low sensitivity when screeners that have been developed and validated through large networks like OCHIN are suddenly compressed by vendors like Epic. It can be a bit challenging, although the specificity is reasonable. But some notable challenges have emerged during the collapse of the longer screeners into the short EHR form. Perhaps one of the most notable is when screening for interpersonal violence. When adapted from a validated screening instrument to a shorter EHR friendlier one, the Center for Medicare and Medicaid Services version of the HIT screener for interpersonal violence actually resulted in quite a bit of perversity. Participants reporting physical violence through a narrative with their primary care provider did not actually screen positive for any such concerns on the screener, to a profound degree, to the point where the screener was worse than flip of a coin doing nothing. And so we have to be careful about that. But just to conclude my litany of bad news before I try to describe what will hopefully be some better news, the other challenges around implementation that have been brought out from both the Socin network and Siren and other networks have been, of course, the details of the implementation. In many states and other localities, we in primary care have been asked to implement closed loop referral systems. There's a variety of software vendors for these. They often have very high level contacts in the state government. And essentially, the theoretical idea is implement a software system, allow us to do screening, auto populate referrals. The community based organizations and others receive those referrals. It all sounds rather nice, but the implementation in practice has faced numerous challenges. One, of course, is that these are not, you know, landing in isolation. We have our own across practices existing referral processes. We have mandated tracking tools within healthcare that can differ from those in which community-based organizations are in. E-referrals and new technologies are not simply easily adopted in any setting. Certainly not one as heavily regulated and rife with IT challenges as our healthcare system. And there have been a lot of time and practicality issues that results in overall this line summarized here by Gregory Paulson and colleagues, in which enthusiasm is so much more than actual use, unfortunately. Um, Multiple strategies of good implementation science were implemented but did not work across many different implementation attempts in many different states. And so in concert, several of the community-based organizations reported that they felt a slew of untriaged, large-scale referrals arriving at them. So in this assessment, a number of food banks, for example, would receive both people who are mildly food insecure and people for whom they couldn't get through the end of the week without food assistance. And if one receives all the referrals at once with no further triage, you can imagine it's challenging for the community-based organization to know which of these auto rapidly created referrals are actually the ones to address principally and the ones to wait for or engage with less intensity. Overall, the systems have been pushed forward nevertheless, and perhaps one of the largest approaches to these has been tested through randomized controlled trials. This one, for example, being published just this past week in Health Affairs, found that this navigation attempt to connect patients with community resources did not significantly increase the actual rate of community service provider connections or the rate of needs resolution, what we're trying to get to relative to the randomized control group. And findings from the interviews with the staff, the community service providers, and the beneficiaries, our patients, identified challenges actually getting connected. And when connections were made, the resources were often insufficient to resolve the beneficiaries' needs. So unfortunately, no significant differences in this large multi-center, multi-state randomized trial of such social needs screening and referral. This is not the only trial to have those results. Unfortunately, it's perhaps the 17th or 18th to have such results. I haven't found too many trials that actually have a countervailing result, unfortunately, but there is one interesting spotlight that differs. And so the question arises, what did these folks do differently? In a rather large trial in which folks were not just screened and referred, but actually a different approach, an approach in which the patients were assigned to community health workers and had a semi-structured narrative qualitative interview, much longer, much less efficient than a rapid screener. And it was conducted outside of the primary care practice. The practices could identify patients they were worried about, but otherwise it was a so-called pull service. The community-based service essentially looked for folks who may be under accessing the systems, and even by census block, looking at areas that one would expect need, but that there was low enrollment in various programs. a proactive qualitative interview was conducted with patients to understand their needs, and then accompaniment with a community health worker through the course of going to different resource referrals, actually following through in the application processes, actually visiting, for example, PCP clinics, gaps in care clinics, and other associated resources. Unlike many trials I've seen, this large study actually had a reduction in ED visits and inpatient admissions, as well as total medical expenditure. Not all costs of the intervention were fully compensated through the reduction in healthcare spend, but the overall social needs of the patients were indeed addressed significantly as compared to the control group, which had the status quo usual clinical care pathways. And so a question I have is what were these folks doing differently that many of the other studies um, and approaches weren't? One of the key differences is if you go through this study and one or two others that seem to find some pretty nice success rates, in retrospect, the differences in what resources are being connected to are very different in the sense that just like we have variations within our primary care practices in what is considered an evidence-based intervention, and even within the same practice, we have a wide variety of practices going on, and hence the need for quality improvement. So do our community-based organization endpoints. And so, a housing referral is not a housing referral, the same way as a primary care clinician addressing heart failure. In my own clinic, I'll fully admit there are some patients I see, and they might be indicated for SGLT2 inhibitor or uh, uh, spironolactone, but they're not on it, even though the current guidelines suggest that they should be, and no one has prescribed it to them. And so there's a wide variety of guideline-based practices within the fields of housing and food and transportation and so on. And the social needs implementations are themselves important to address. What we've found is that there are some pretty consistent subsets of the social need endpoints that have very good, solid, evidence-based execution. The question is which ones? How can we support those? And similarly, how can we support the community-based organizations or other endpoints that aren't providing evidence-based services or for which it's inadequate to kind of get up to guideline-based care, so to speak, for social needs, the same way we expect to be up to guideline-based care for clinical medical needs. Among the best efforts and most robust literature are federally funded interventions in this space, particularly for food transport and housing. The Supplemental Nutrition Assistance Program consistently shows benefit across states and territories, although there's variation, marked variation in how accessible it is. Some states continue to have barriers to application processes, such as lacking electronic applications, requiring multiple forms of verification before one can enroll. It used to be the case that some also required fingerprinting for no particularly obvious reason, other than to perhaps discourage application entry. And no matter which way one conducted the observational analysis, because it's difficult and probably unethical to randomize hungry people to SNAP or a control group, the various observational approaches and in which one uses, for example, differences in states and enrollment as a kind of instrumental variable, a semi-randomizing quasi-experimental factor to understand SNAP's benefits, we see an actual savings in health expenditure across the board. Similarly, some housing programs, particularly housing first programs, appear to have robust effects on healthcare spending, not to the degree in which they self-pay, but to a degree in which we do see some improvements in avoidable health expenditure through complication reduction, especially in the substance use domain, but also across chronic conditions. This is an example from Maryland, for instance, in which proactive investment in sort of requirement-free housing with a relatively low barrier to entry among patients with chronic conditions resulted in overall net savings for this particular population as compared to the housing development costs and the housing maintenance and the associated care coordination. But again, not all housing is created equal. Parallel housing programs had null results when they didn't, for example, include a particular standard of housing, didn't have close care coordination within the lobby of the housing, didn't have integrated behavioral health visiting patients who were in the housing. It wasn't quite as effective. So we asked the question, we have so many different social needs that we face and that we evaluate in primary care. And we have so many different endpoints that vary geographically from town to town. We have the most robust evidence for a subset of social needs interventions, particularly in domains that are very common, like food and housing, and less so in other domains that are important but have just been less studied. And we continue to see the bridge to nowhere being a major problem, by which I mean if one is connecting to a resource that doesn't have adequate space for the patient we're connecting to, that is a major problem. And if they're not abiding by the best evidence for how to deliver their food intervention or housing intervention or whatever intervention, that's a secondary problem, both of which require funding. How much funding and how do we get that funding? What we did is systematically cataloged, which took a few years, across census blocks, tracts, and counties and states across the country, for all 50 states, DC, and Puerto Rico, the level of available resources in 4 major domains that CMS has advised are key domains that are common in social needs screening: food, transport, housing, and broadly care coordination services, which typically means care management, case management, or community health worker programs. We looked at the existing resource availability, bed availability, person month availability, the existing referral base, estimates of demand from community-based surveys like the geolocated version of the National Health and Nutrition Exam Survey, other surveys related to housing, different community-based surveillance counts. And we compared availability of resources to demand, existing evidence-based practices within each of those domains across the community-based and governmental organizations providing those resources, and conducted essentially a simple supply and demand calculation across all of these locations. We also linked the patients back to their assigned and attributed primary care providers to understand a bit about what type of providers and experience which patients and are providing care for which patients and how that corresponds to the availability of resources for those patients. We then did an economic assessment. We said, let's see what the best estimates of needs are according to the community-based surveys, door knocks, et cetera. How many people would be eligible for different types of programs, and how many people are ineligible but need a service, and the service eligibility criteria too restrictive, versus how many folks are facing a bridge to nowhere, even if they are eligible, the food bank or the housing service, et cetera, just doesn't have enough capacity to help them. And therefore, what are the costs associated with shoring that up? Secondarily, once they do get in, or if eligibility or capacity changes with that funding to help them get in, what are the maintenance costs for continuously supporting them? We looked across programs that had strong evidence. In the food domain, there's lots of studies, from SNAP to the Women, Infants, Children program, child nutrition, emergency food assistance, particularly for seniors, meal delivery, medically tailored meals, food vouchers. In the transport, the most literature we found was in the non-emergency medical transport. This is, of course, separate from ambulance-based transportation. And then in the housing domain, there's a variety of studies: Section 8, HUD housing, housing for subsidies, that includes vouchers under Section 8, and community health worker accompaniment or other kinds of case management and care management services. Those are the domains in which we found strong literature, including randomized trials across a variety of populations, for which we could say, aha, we have a cost estimation and effect estimation from which we can run with the idea of doing an infrastructure-based calculation. So here are the first set of results. This is coming out next week in JAMA Internal Medicine. The results indicated a few key findings. First, we found that typically food and housing interventions were limited by low enrollment among eligible folks due to the inadequate program capacity. That's probably unsurprising to the OCHA network, especially for housing. It's more the capacity than the eligibility that was posing an issue. By contrast, the transport and care coordination interventions were more limited by having very narrow eligibility criteria. Many patients reporting they need the transport or they could benefit from care coordination services and assistance or navigators or accompagnators, but the eligibility required often not esoteric, but having multiple chronic conditions or a specific behavioral health condition and omitted a large volume of patients. And so depending on the particular intervention, the initial budget increase would need to come either through capacity increases, particularly around the food housing side, or by eligibility increases that were actually disproportionate to the allocated budget, particularly on the transport and care coordination side. Who were serving the patients that were particularly affected in terms of having funding and not having funding? No surprise, this crowd at OCHIN had the highest need patients. As a proportion, had some federal funding, but also had among the greatest not federally funded subsets. Peer practices that were urban in high poverty zones and did not meet criteria or were not registered as federally qualified health centers had about an even breakdown, but less overall totals, a little bit higher for rural, and unsurprisingly lower for practices in lower poverty zones. And also unsurprisingly, variations by area deprivation index were as one would expect in terms of where populations reside. What was interesting is just the complete break off of federal funding availability once one looked at communities that had high inequality with concentrated poverty, so that the overall community as designated by the census had low area deprivation, but actually there were highly deprived subpopulations, such that high inequality communities were systematically excluded from federal funding because of the overall community not being homogeneously poor. And so I'll come back to that. Overall, the estimated cost from these domains was not insignificant. On a capitated basis, about $60 per member per month. A minority of that was on what was actually available for spending currently, screening and referral. A majority of it was unfunded, and less than half actually had federal funding currently allocated. So this indicates to me that the bridge to nowhere is the majority of funding need, meaning actually providing capacity to accept our referrals is where the majority of funding gap is. And in addition, that the funding amount total is quite a bit higher than what typical capitated payments are for social needs, which I've seen in the domain of a fourth or a fifth of this number. In general, what's particularly interesting is on a per member per month basis, because 1 in 7 Americans on average, and of course in OCHIN clinics much higher, are food insecure, the sheer cost of the delivery on the food side was heavy. I would have expected it to be heavy on the housing side, but it's actually due to some of the volume on the food side, that particularly transport costs associated with food infrastructure are particularly heavy. Although on a per marginally housed patient basis, the costs are high on the housing, it's not on a population level. Again, screening and referral being a component of cost, but certainly not the heaviest cost, and disproportionate to how funding is allocated currently. So how are we going to pay for this stuff? This is the crux of the dilemma. We can ask for funding, and we do many times from within the OCHA network and outside in primary care. We ask for funding for our patients. Where can it come from? There's the traditionalist liberal argument, which is from taxing the wealthy, and I'm sympathetic to it. If you look at tax rates, here's a distribution of income. Here are people in the top 1% on the right side of this nonlinear graph, people in the top 0.01%, and their effective tax rates as of 1970, you can see across United Kingdom, United States, and France. Yes. Interestingly, France did tax the rich less than us in 1970. Always interesting. And then you can see it as of 2007 when this graph was produced, um, whose curve downwards is both the United Kingdom and the United States. If you were to look at more recent data in absolute numbers, you can actually see a dip towards the highest portion of the population that's been decreasing steadily since 1950. Most others actually in the less than 99th percentile range have not been affected in terms of their total tax rate over the last 70-ish years, interestingly. Now, a wonderful writer, Matthew Desmond, argues in his new book, he wrote the book Evicted, which I know many of you read. He has a new book out, which sort of codifies the common argument. We could just about fill the entire poverty gap in America if the richest among us simply paid all the taxes they owed. Social programs rescue millions from social ill, but they do nothing to address its root causes. We need to ensure that aid directed at poor people stays in their pockets. So he argues for unbound, less restrictive social need addressal. I'll talk a little bit about some alternatives that have been posed and put into place. So we all know that this is politically challenging, right? This is not a new argument. In fact, it's quite historically old and been posed for many years, but has been quite difficult to implement in practice, particularly at the federal level, and actually a little bit less so at the state level, but widely varying across states, no surprise. What some have argued, and I'll review some of the evidence on how well or poorly this has worked, is to try to understand the central argument behind tax avoidance or tax evasion, depending on your definitions and political perspectives. If the wealthy, and actually most people, are keeping income, if they have income, and if they have surplus income, by which I mean that they actually have some reserves as after they pay their expenditures, where are people keeping the money? Most folks, either through choice or by default, are keeping it in private investments, by which I mean it could be private investments as simple as a bank account, but actually the majority of Americans with surplus don't keep it in bank accounts. They keep it in investment firms, mutual funds, retirement accounts. A large chunk of those people are not actively maintaining those, meaning it's passive. Perhaps their employer provides a 401k or a 450B, or there's many different numbers and letters attached to it, but they're all different types of plans. Or perhaps they are actively keeping things in funds, whether it be stocks, bonds, mutual funds, ETFs, again, acronym soup. But the point is they're in some form of private investment. They expect a return on that. There's some sort of interest or earnings that they will probably dip into during times of need. Car purchasing, home purchasing, paying for kids' education, and most of all during retirement, presumably. Then what if there is an additional vehicle in which people can continue to use those funds, but instead of those funds going to private companies, they actually supplement uh, public services? So the issue is often termed a social impact bond. They've been popularized more in the United Kingdom, although are in place kind of under the radar in the United States. The idea is that the government issues a bond, and rather than the bond necessarily being for road construction and so on, it's actually for delivering a social service. The government looks at what their expenditure would have been without that social service and what it would have been with that social service. And the difference in the funds is split between the government keeping some of the savings and the private investors who put up the funds for the bond keeping the rest of the savings. So, for instance, here's a case that has quite a bit of robust evidence, perhaps the longest randomized trial follow-up that I've ever seen, in which a group of um, public health and healthcare primary care providers worked on home visitation for their patients during the prenatal and infant period. So nurses would visit their homes, they would address social needs, they would coordinate care with OBs and primary care providers and pediatricians, and overall maternity outcomes were quite positive. And in fact, the outcomes for the children were quite positive. So not just talking about savings from neonatal ICU expenditures that would have been charged to Medicaid typically, or outcomes, but also outcomes related to incarceration, educational outcomes, special social services that would often have been required, CPS and associated, such that overall the government saved quite a bundle with a significant 18-year follow-up period following the trial, just all from this perinatal intervention. So in order to continue funding, now the funding was actually temporarily cut from this particular program, but a social impact bond was actually issued in order to continue the funding and maintain the program over this follow-up period. And the difference is split between the bond investors and the government in order to sustain this. These are the net outcomes from the governmental perspective in terms of public taxpayer savings, actually split between the bond issuers and in this case, state government for this intervention. Now, some others have argued that it's very difficult to calculate and observe randomized control trial, let alone robust cost savings differences. And we should not be demanding for cost savings from our social needs interventions. We should do it because it's the right thing to do. Many of them of the social needs interventions may improve a social need, but may not result in net healthcare cost savings. A group out of the Impact Poverty Lab at UPenn has also indicated that we view social needs interventions in isolation, a food intervention, housing intervention, and so on, whereas often it is aggregate and comorbid needs that go unaddressed. And so they're participating in a trial that in which they simultaneously address what community members have, through a kind of road mapping process, elected as being the common collective social needs that run together in their particular community, this being a particular location in Philadelphia. And by conjointly funding in this way their social needs, we'll examine their kind of collective impact on the actual social need benefits and subsequently on outcomes that go beyond healthcare cost savings and into the realm of what would have been overall expenditure in terms of other social badnesses, incarceration, violence, associated police spending, and include that in some of the cost savings calculations. Of course, I would be remiss if I didn't also mention the results of trials that have been on unconditional spending. Most of the social safety net programs I've discussed have focused quite heavily on the inclusion criteria issue. You have to do something and spend money only on this one subset of goods because we're worried about you diverting your money to drugs and alcohol and other things that are considered social evils. And yet, from the first set of trials that are coming out on universal basic income, we don't see that diversion happening. We see it being spent on basic needs, contrary to popular belief. The early stage results of our trial on universal basic income in Northern California, which is a modest amount, $500 a month, with a modest sample size, 125 people in each arm, over the first 2 years includes improvements in infant birth weight and significant improvements in mental health outcomes, PHQ-9 and GAD-7. We'll have to follow these folks for longer in order to see other outcomes as we go. But this is one of the first experiments to be able to identify whether a sort of unconditional cash transfer is actually meaningfully helpful as opposed to splitting up social needs interventions into different categories, each with restrictions on how to use the cash. We've also found that cash as opposed to a voucher or restricted spending is more beneficial the more severely limited a person is. So if somebody is more and more food insecure, cash tends to be better than a voucher because they can use that money allocation for other things like having to go between rent, car expenditures, and food, and having the flexibility to deal with uncertainty more as opposed to having a bunch of restricted social needs. And in fact, we're now accounting for the administrative cost of having so many different restricted siloed programs, which is a pretty significant overhead cost for programs, particularly at the state level. Of course, California is also embarking, and some other states perhaps too, on one form of unconditional cash transfer, which is attempting to address a systemic historical inequality, which is in the form of reparations. This group also at Penn examined the impact on expected survival and indicated that simply providing that particular transfer would be expected simply from actuarial mathematics to essentially close the survival gap between Black and white adults in the United States. We'll have the opportunity soon to actually prospectively study that as the reparations are beginning in the California setting. So in order to leave some time for questions, I'll talk a little bit about where we are in this research and some questions that we need to explore more. One big question that I alluded to in the beginning is the offloading from primary care staff members. As we go through the process of trying to focus so much on screening for social needs, what can we do in parallel or through new programs and staff that won't simply add more to the plate? Can we improve closed loop referral systems? The idea that a technology would solve our social needs is sort of perverse, obviously on its face, but has nevertheless been sold across the United States. And so can we actually get this system of software to be implemented more effectively and actually address some of the ways in which people are needing evidence-based social needs interventions? What are the longer term impacts of social impact bonds versus conventional instruments for funding? Are they merely ways to undermine increasing taxes on the rich and instead allow for more of a flexible strategy for people sheltering their investments? Or are they truly a mechanism to increase overall social needs funding? And what are the longer term impacts on universal basic income and other kind of combined social support efforts? I'll thank the many folks who worked on these research projects. Please feel free to email me if I can assist with any questions, but I'll stop there and answer any questions you might have. Thank you.
All right. Thank you, Dr. Basu. And if attendees have questions, please type them into the chat or Q&A box. And we'll start here with this one. Regarding social needs interventions, what kind of feedback have you heard from clinic staff or patients?
Thanks. I feel like qualitatively, at least the studies we and others have done on feedback from staff and patients has been in three clusters of findings. One is staff overwhelmment with another thing to screen for. Mixed with appreciation for the need and understanding a need, but wondering what else we can do besides kind of rapid screening. The second on the patient side has been concerns about how the data are being used. Disclosing something very sensitive, oftentimes to a staff member who may not know the patient as well as say their primary care provider, but the primary care provider has limited time during the visit. And so often it is another staff member who's doing the assessment. And also, what is the appropriate location? We're seeing it roll out, for example, not just in primary care practices, but also in many emergency departments. When is it appropriate to breach those questions? It may be in several instances. On the other hand, it may be very inopportune and people kind of clicking through a checklist just to get through the checklist, leaving the patients feeling railroaded or otherwise with a poor experience. And so I'd highlight those, and certainly top of mind is just how poorly some of the software implementations have gone for folks. The IT pain is real, and I think needs to be addressed appropriately as part of these efforts.
Thank you. And again, if there are questions, please put them into the Q&A or chat box. This next question is, if a health system or clinic is interested in participating or financing a social needs intervention, what are some things they should consider and what are some good first steps?
But um, drawing from small sample size, what I've seen work when health systems or practices are interested in participating, say, in social impact bonds, is to discuss particularly with the states, oftentimes the state, rather than the county um, treasury department. So typically bond issuance is actually something which commerce departments and treasury departments discuss quite a bit with education providers. So local community colleges are often the beneficiaries of state issued bonds, for instance. The other groups are often transportation related, such as construction related bonds. And they don't often hear from healthcare entities, but when approached, many of them are actually quite intrigued um, and willing to at least coach folks through the process. So I've seen, 4 or 5 practices or practice consortiums that have participated in those kinds of social impact bonds, often around state agendas such as reducing maternal deaths, improving funding for substance use, and other items that are frankly getting attention at the state house level.
Thank you. And have you noticed any differences in challenges financing social needs interventions between the urban and rural clinics? So they seem to be about even on the slide, I remember.
In terms of federal funding allocated, yes, they're even despite disproportionate need among some of the more rural practices. So certainly have noticed big differences. A lot more concerns about perversity when screening and referring to a non-existent service in many of our rural um, participants, among many of our rural participants, versus among many of our urban participants, a concern of sending a large volume of untriaged patients. So people who are not totally differentiated to a community-based organization and need further kind of risk stratification or need stratification before they're transferred over.
Right, thank you. And we are coming up close to time. So final question would be what, oh, we got a question. Here is the final question. Can you comment on the community hub model that HHS, Benjamin Summers et al., advocated for as a solution? They suggest that blending and braiding of funding sources might sustain these models and describe them as follows. Community care hubs, community-focused entities supporting a network of CBOs providing services addressing health-related social needs, which centralize administrative functions and operational infrastructure. From your perspective, is this a realistic and financially feasible solution to the piecemeal reality we live in?
Thank you for the question. So I think it's to be determined through randomized trials and natural experiments, as with any of these other interesting ideas of whether having some of the centralization around administrative and operations can help. Certainly, it's not entirely new in the sense that many states have instituted such hubs so that people can go to, let's say, a central navigation center, it's called in some states, and essentially have coordination of services across multiple domains, one of which may include healthcare services, but others often being housing, food, and related social services, including case management. And so the financing has been a challenging piece, as these often have been funded through temporary grants. And so as the grants come and go, the hubs or navigation centers have come and gone. And so the question is, can they be tied to some source of funding that might be more sustained and enable them for longer term? And do they really improve on some of the availability? It seems to be highly execution dependent. For example, within some studies of the navigation hubs in Northern California, it was very inconsistent findings across 3 large cities, where the specific local implementation of protocols at the hubs determined often quite a lot about how well they were utilized, how much actual social needs connections and resolutions were occurring through them. And some of it also very attributable to how well they had buy-in from the local community-based organizations rather than being, say, imposed from outside. It's a great question.
Thank you, Jonathan, for that question, and thank you, Dr. Basu. All right. Well, I want to say thank you, Dr. Basu, for that incredible presentation, and thank you to everyone who attended today's session. Please be sure to follow Waymark on Twitter at Waymark_care. That's at WAYMARK, the underscore symbol CARE. And find their website at www.waymarkcare.com. And be sure to check out Dr. Basu's book, The Body Economic: Why Austerity Kills. And be sure to follow Ochin on Twitter at Ochin Inc. That's at OCHININC, and over on LinkedIn. In addition, head over to ochin.org and advancecollaborative.org to read the latest on our research studies, blog posts, and upcoming events. And don't forget to visit our Ochin YouTube channel to catch up on those past Grand Rounds presentations. And Ochin Grand Rounds will return for our Season 7 finale on June 29th from 12 to 1 p.m. Pacific Time, where we welcome Dr. Douglas Krakauer of Beth Israel Deaconess Medical Center, the Fenway Institute, and Harvard Medical School, and Dr. Julia Marcus of Harvard Medical School, Harvard Pilgrim Healthcare Institute, and the Fenway Institute, as they present on prediction using electronic health records to disseminate and implement clinical decision support tools for PrEP. Invitations to this presentation will be sent 2 weeks prior to the event, but if you are not on our mailing list and are interested in attending this or any future event, please email me at grandrounds@ochin.org. That's grandrounds, all one word, grandrounds@ochin.org. So from all of us at Ochin and Dr. Basu to all of you, have a wonderful rest of your day, a great Memorial Day weekend, and stay healthy out there.